Okay, let's talk about airway pressure release ventilation, APRV. This will just be a brief description of APRV, kind of an overview. APRV means that we allow the patient to breathe at two different levels of CPAP. We'll set a pressure high or P high and a pressure low or P low. We also set a time high or T high and a time low or T low. We'll allow the patient to breathe spontaneously at the T high and theoretically also during T low. However, usually the T low is set so short there's not enough time for the patient to breathe spontaneously. Therefore, really the patient's breathing spontaneously only during time high. It's designed for use with artificial airways. However, some people do use it for non-invasive ventilation as well. Because a patient's breathing spontaneously, it provides partial ventilatory support. However, it can also be used for patients that are either heavily sedated, anesthetized, or even paralyzed. Some people believe in using neuromuscular blockade during the first 24 to 48 hours of ARDS or first 24 to 48 hours of APRV. This is a figure that I took from Dr. Habashi's article, the assigned article in Critical Care Medicine 2005. It shows pressure being graphed on the upper waveform, pressure's on the y-axis, time is on the x-axis. On the lower waveform, flow's on the y-axis and time's on the x-axis. You can see that when T high begins, the pressure goes up to about probably 18 centimeters of water and remains at that period until the end of time high. Then it drops down briefly during time low. Then it immediately returns back to the high pressure for the duration of time high. We set the pressure high. We set the time high. We also set a pressure low, which usually is set at 0. However, time low is set so short that we end up with auto PEEP, so this pressure shouldn't drop back down to 0. During time high, the patient's allowed to breathe in spontaneously. You can see a spontaneous inspiratory flow rate that's rather sinusoidal, then an expiratory flow also. During that time, if you were to line this up, you would see the airway pressure during inspiration drop briefly. Then during exhalation, it will go positive, usually about 0.5 to 1 centimeters of water. In this case, the patient's taking 2 spontaneous breaths during T high. This is an article that was published in the Cleveland Clinic Journal of Medicine. They reviewed multiple articles to try to determine the physiologic effects of APRV, and they showed that APRV does improve oxygenation primarily by improving distribution of ventilation and improving venous return, that APRV frequently results in a reduction in the use of sedation, anesthesia, and neuromuscular blockade. APRV usually results in improved hemodynamics, specifically in improved cardiac output and improved blood pressure, because the patient has an increased venous return due to the spontaneous breathing. Also, there's improved respiratory mechanics by the elevated mean airway pressure. It recruits alveoli and increases the compliance. However, in reviewing the articles, they stated that there was no reduction in mortality. This is one of the assigned articles by Roy and Habashi, and they evaluated pigs, 7 pigs that were given a reperfusion sepsis and tried to induce ARDS. The 3 pigs that were ventilated in the traditional fashion developed ARDS. The 4 pigs that were ventilated with APRV did not develop ARDS. So their conclusion is that APRV may prevent the progression to ARDS. However, I think we need to be very careful with this because this was a very small study and it was a study done on pigs, not on humans. Some of the advantages of APRV, primarily we can control the airway pressure. Since we control the airway pressure, we're not going to have a sudden increase in airway pressure. We can elevate the mean airway pressure. By elevating the mean airway pressure, we should reduce atelectasis. We should help to increase compliance and increase the FRC. Also, because we're using a patient breathing spontaneously in CPAP at an elevated PEEP level, we will have a reduction in the peak airway pressure. APRV is designed to allow the patient to breathe spontaneously, and as I said earlier, it generally will enhance venous return and it should improve the VQ. By improving the VQ and by enhancing venous return, by a reduction in atelectasis, oxygenation is usually improved with APRV, primarily from the alveolar recruitment and the improved VQ. And again, as I said, there is possibility that it may prevent the progression to ARDS in some patients. However, that is very questionable, I think, at this point. There are several disadvantages with APRV. One of them is the tidal volume is variable. It is a pressure-targeted mode, therefore, as the patient's effort, resistance, and compliance varies, the tidal volume will vary. Also, some people feel that there is an increased work of breathing while the patient is breathing spontaneously at PEEP high. Another factor that we need to consider is the transpulmonary pressure. Now, as Jeff talked about earlier in the semester, transpulmonary pressure is the alveolar pressure minus the pleural pressure. For example, if you had an alveolar pressure of 25 and a pleural pressure of a -7, if you take 25 minus a -7, that equals 25 plus 7, or in this example, the transpulmonary pressure would be 32 centimeters of water. We want to always try to keep the transpulmonary pressure as low as possible, definitely below 30 centimeters of water. However, if we're using a P high of 25 or 27 centimeters of water and the patient is allowed to have strong inspiratory efforts, the pleural pressure may be rather negative, which increases the transpulmonary pressure, which may result in an increased ventilator-induced lung injury. Also, we said that the tidal volume is variable. With the release volumes, it's possible, depending upon the delta P, the delta P is the P high minus the P low, and depending upon the patient's expiratory time constants, the size of the ET tube, and the exhalation valve, and the time low, the release volumes may be very large, may in fact exceed the 4 to 6 mils per kilo that we try to stay less than. Some authors feel that spontaneously breathing in early ARDS may actually worsen the clinical stability, impede recovery, and worsen outcomes. Another issue with APRV is the availability of APRV. Several different ventilators have a mode that may appear to be similar to APRV, but it really may not be the same thing. For example, bivent and biphasic ventilation is not the same as APRV, and it may result in lengthening of the time low at different times of the cycle. If it lengthens time low, it will increase the chance of alveolar de-recruitment. One of the last disadvantages, which I think is very important, is the lack of clinical evidence for APRV. We have evidence that it improves some of the physiologic parameters, but we have minimal, if any, evidence showing that it reduces mortality. The initial settings that I have here listed here are from Hibashi's article on critical care medicine. Even though this was in 2005, it's still the standard, and these values are still currently being used. Dr. Hibashi's method recommends setting the PEEP high between 20 to 25 centimeters of water. If the patient was being ventilated in volume targeted ventilation, you might set the P high equal to the plateau pressure. However, if the patient were being ventilated in pressure control ventilation, you might set the P high equal to the PIP in pressure control. The time high is usually set at 4 to 6 seconds. Generally, you will set the time high at 90% of the total time. For example, if you had a time high set of 5 seconds and a time low set of 0.6 seconds, your percent of total time would be 89%. This would be an appropriately set initial time high. The P low, according to Hibashi's method, is usually set at 0. He sets it at 0 to allow a larger delta P for expiration. The time low is frequently set at 0.4 to 0.8 seconds, but we usually set the time low so that time low ends when the expiratory flow is 75 to 85% of the peak expiratory flow rate. Now on the next slide I'll show this a little bit more. Dr. Hibashi also recommends in using ATC at 100% of the properly set ET tube. This is a screenshot from the Draeger V500. With the V500 you can plug a USB flash drive into the side of the monitor and press export, and it will export a screenshot. It can also export all data if you choose. In this case we're ventilating the patient in APRV. We have a P high of 25 centimeters of water. At the end of P high, the pressure drops down to P low of 0. This is the peak expiratory flow rate. I freeze the screen and then scroll across, and you can export this shot. Then you can pick this point, which is the peak expiratory flow, and that value is displayed up here, and the value for the peak expiratory flow is 59.9 liters per minute. Then if you scroll across to the point where T low ends and it goes back up to P high, that point in this case is right here. The numeric value for that is 28.7. To get the percentage, you would take the 28.7 divided by 59.9. That equals 47.9%. Ideally, we would probably decrease the T low so that T low would end when the flow is at a higher level, which would increase this percentage closer to the 75 to 85% that Dr. Hibashi recommends. There are several different ways to decrease the PaCO2 when ventilating a patient with APRV. One of them is to increase the delta P. If we want to increase the delta P, we can increase the P high. However, we have to be careful and be aware of the transpulmonary pressure as we increase the P high, and try not to go too high to where we're likely to cause ventilator-induced lung injury. In some cases we could also decrease the P low. However, as I mentioned previously, with Dr. Hibashi's method, we usually set P low as 0, so we cannot set it any lower than that. Another method of decreasing the PCO2 is to manipulate the time high. However, this gets a little bit confusing because we will change the T high differently if the patient is breathing spontaneously as opposed to if they're not breathing spontaneously. For example, if the patient is not breathing spontaneously, meaning that we have sedated, anesthetized, or paralyzed the patient, then if we want to decrease the PCO2, we will increase minute ventilation by decreasing time high. This provides more releases, which basically is like a higher rate, which increases the minute ventilation. However, if the patient is breathing spontaneously, we'll do this differently. If they're breathing spontaneously, we will increase time high. As we increase time high, it increases the mean airway pressure, which results in better alveolar recruitment and an increase in the alveolar capillary surface area and an increase in the alveolar ventilation. So if the patient's not breathing spontaneously, we can decrease time high to allow more releases and a higher minute volume. If the patient is breathing spontaneously, we increase time high to increase the mean airway pressure, to recruit more alveoli, increase the surface area of the alveolar capillary membrane, and increase alveolar ventilation. Another way to decrease the CO2 is to increase the time low. This will allow more gas to be exhaled during time low. However, we have to be careful and still stay within the constraint of 75 to 85% of the PEFR. If we increase T low too much, we are likely to cause de-recruitment and collapse. To increase oxygenation with APRV, we usually try to increase the mean airway pressure. We can do that by increasing P high or by increasing T high, possibly by decreasing T low, and we're probably not going to change the P low. When we want to wean patients during APRV, we do what's called stretch and drop. Stretch means to stretch the time high, and drop refers to dropping the pressure high. For example, we may increase the time high by 1 second and decrease the pressure high by 1 to 2 centimeters of water. This will usually maintain a fairly constant mean airway pressure. If after making a change of stretch and drop, if the patient's respiratory rate increases by about 10 breaths per minute, or the minute ventilation decreases by 3 liters per minute, then you may consider moving back to the previous ventilator settings. As you continue to stretch and drop, once you reach a P high of about 10 centimeters of water, you can change the patient over to CPAP at 10 and then progress towards a spontaneous breathing trial. Earlier I said excuse me, that there's not a lot of evidence for APRV. When you go to clinicaltrials.gov, you can look at what trials are currently approved and underway. When you search for APRV and ARDS, you'll notice that one of the first studies that comes up is a study on APRV and ARDS out of the University of Tennessee at Chattanooga. The primary outcome of this study is all-cause mortality. The secondary outcomes are the number of ventilator-free days and the length of ICU stay. I think this is a very valuable study. This is the first study that I have seen that is a large study incorporating primary outcome measure as all-cause mortality. This study is currently recruiting patients, and I think that once this study is completed, if it is, and the results are analyzed and published, if they are, it could be very useful and give us information that we need regarding outcomes, primarily mortality, with APRV. There are several other clinical trials that are underway. One of them, the primary outcome is oxygenation. Another one is sedation. And another one is inflammatory mediators. While these outcomes are important and clinically useful, they are not the primary outcome we are most interested in, which is mortality. So the future for APRV. What do we know? It may be useful. On some patients, it appears to be very useful. There's a lot of small studies, anecdotal evidence showing that it has been useful, especially in patients that are morbidly obese, maybe in patients that have H1N1 induced ARDS. However, we don't have a high level of evidence that it reduces mortality. We need to watch the literature carefully. Evaluate the published articles and see if the article that was published is a reasonable article, and if it recommends therapy and treatment that is appropriate for you and for your patients. If you're going to start using APRV, consult with an experienced clinician first. Most of us have used volume AC, pressure AC, PRVC AC, SIMV, CPAP, pressure support, and most of those modes really are rather intuitive. APRV is not intuitive. I think that early on, in order to understand APRV, you need to work with a clinician who has a lot of experience with APRV. You need to read what you can. You need to talk to people about it to develop a sense of understanding of APRV and the clinical management of APRV. One other concept or fact that I think we need to be a little bit careful of is, even though most all ventilators do volume AC or pressure AC fairly similarly, I think that ventilators that have APRV versus bilevel versus bivent do each of these rather differently. I think that the effect on the patient is very different depending upon the ventilator, depending upon the responsiveness of the inspiratory solenoid valve, depending upon the resistance of the expiratory valve, also dependent upon whether or not the time low is truly fixed or whether or not it can be extended by the patient if the patient's peak expiratory flow rate increases. I think we need to be very careful with some of these modes that may be similar but not the same as APRV. I hope that this helped to give you a bit of an introduction and an overview of APRV. I look forward to discussing this with you on Tuesday during the Collaborate session, as well as on the discussion board. Please email me or call me if you have any questions, and I will see or talk with you on Tuesday. Thank you all. Bye-bye.